Sepsis and septic shock are life-threatening conditions requiring immediate intervention. Critical care pharmacists play a vital role in managing these emergencies by optimizing antimicrobial therapy, monitoring hemodynamic status, and ensuring timely administration of vasopressors. Understanding the pathophysiology and pharmacotherapy is crucial for improving patient outcomes in these complex scenarios. Sepsis and septic shock are life-threatening conditions requiring immediate attention. Understanding the sepsis 3 definitions is crucial for accurate diagnosis and management. Pharmacists play a vital role in optimizing antimicrobial therapy and supporting multidisciplinary care, ensuring effective treatment and improved patient outcomes. Sepsis and septic shock are critical conditions requiring precise definitions and understanding. The sepsis 3 definitions highlight the importance of recognizing life-threatening organ dysfunction and persistent hypertension. Diagnostic criteria involve quick sequential organ failure assessment and sequential organ failure assessment scoring systems. Initial management focuses on the Hour 1 bundle, while pharmacists play a crucial role in optimizing antimicrobial therapy and supporting multidisciplinary care. Sepsis is defined as life-threatening organ dysfunction due to a dysregulated host response to infection. Septic shock is a severe form characterized by persistent hypertension requiring vasopressors and serum lactate levels above 2 millimoles per liter, despite adequate fluid resuscitation. These definitions align with Sepsis 3 and Surviving Sepsis Campaign 2021 guidelines. Screening for sepsis involves the quick sequential organ failure assessment criteria: respiratory rate, chart 22 min, systolic blood pressure, chart 100 millimeters of mercury, and altered mental status. The sequential organ failure assessment score quantifies organ dysfunction. Essential labs include lactate levels, blood cultures before antibiotics, complete blood count, comprehensive metabolic panel, and liver function tests. The Hour 1 bundle is crucial for sepsis management. Measure lactate levels, rechecking if above 2 millimoles per liter. Obtain blood cultures before antibiotics when possible. Administer broad-spectrum antibiotics within an hour of recognition. For hypoperfusion, provide 30 milliliters per kilogram crystalloids. Use vasopressors if hypotension persists, maintaining a mean arterial pressure below 65 millimeters of mercury. Initiate broad-spectrum antimicrobial therapy immediately, targeting the suspected infection source. Adjust treatment based on culture results, sensitivities, and local antibiogram data. De-escalate to a narrower spectrum once the pathogen is identified and clinical improvement is observed. Optimize dosing for patients with renal impairment, continuous renal replacement therapy, or hepatic dysfunction to ensure efficacy and safety. Adjunctive therapies are crucial in managing infections. Source control involves removing infected devices, draining abscesses, and debriding necrotic tissue. Corticosteroids like hydrocortisone may be used in refractory septic shock. Glycemic control targets glucose levels of 140–180 milligrams per deciliter in critically ill patients. Prophylaxis includes venous thromboembolism prevention and stress ulcer prophylaxis as needed. Pharmacists play a crucial role in sepsis management by ensuring antibiotics are administered within the critical 1-hour window. They recommend empiric therapy based on local resistance patterns and infection sources, optimize dosing for renal or hepatic impairments, and monitor for drug interactions and toxicity. Additionally, they support antimicrobial stewardship through appropriate use and de-escalation strategies. A 67-year-old with pneumonia and hypotension requires immediate intervention. Administer broad-spectrum antibiotics like piperacillin, tazobactam, and vancomycin within an hour. Begin fluid resuscitation with 30 milliliters per kilogram intravenous crystalloids. If mean arterial pressure stays below 65 millimeters of mercury, initiate norepinephrine. Continuously monitor renal function, adjust antibiotic dosing, and reassess lactate clearance for optimal outcomes.